So today we're going to be inserting an oral pharyngeal airway, commonly known as an OPA. In your kit there will be many different sizes, usually the green fits all patients. To measure we go from the mandible to the mouth, fits here, so what we're going to do is going to start by tilting the head back. You put the OPA in facing you. When it gets to halfway you give it a 180 turn and it pushes down. This avoids getting the tongue caught. So the complications to inserting an OPA is if it's too big, it can damage the airway. It can also induce vomiting on the patient. And we only use an OPA on patients that have a GCS scale of less than 8 or a verbal scale of less than 2. So today I'm going to insert an NPA, which is a nasal pharyngeal airway. So there's various different sizes. So what I'm going to do first is I'm going to measure from the nose to the mandible. That's far too big. As is that one. Cool, we found the right size. Usually it's about 7.5 millimeters. So what we're going to do is make sure that the NPA is well lubricated with a water-based lube, and we're going to insert at a 90-degree angle into the nostril. If there is a bit of resistance, turning on a 180 degrees angle can also assist the insertion. We're going to insert until the flange reaches the nose. As you can see, there's a bit of resistance, so what I'm going to do is I'm going to change nostrils. If that happens, then it is always beneficial to change nostrils. There we go. Now the NPA is inserted. We use an NPA on a high GCS scale. You can also use it when an OPA can't be used. The benefits of an NPA is that there's no gag reflex, there's no vomiting. You can insert it on a high GCS patient or a patient with trismus. However, complications include bleeding and nasal polyps. So, I'm just going to test the suction unit here. How we do that is we stop the air from coming through, we turn it on. So it reached the top, so we know that it is working. Let the air out here. Another way to test is just cover your finger with over the rigid catheter, and you can feel the suction. So to suction my patient, what I'm going to do is make sure he's on his lateral side. Then I'm going to insert the rigid catheter just as far as I can see and do it in a circular motion. So it needs to be in his mouth for no longer than 10 seconds, and it must not be used in a moving vehicle. So today I'm going to take Kate's vital signs, which include her radial pulse, blood pressure and respiratory assessment. When taking the radial pulse, I'm counting the number of beats over 15 seconds and multiplying the value by 4 to get the beats per minute. If Kate was unconscious, I would take her pulse via the carotid pulse. So, Kate, is it okay if I take your radial pulse?
Sure.
Awesome. Kate's radial pulse is 80 beats per minute, which is within the normal adult range of 60 to 100 beats per minute. Her pulse was also regular and strong, which indicates normal cardiac function. So I'm now going to take Kate's blood pressure by measuring the systolic and diastolic blood pressure values. Is it okay if I take your blood pressure, Kate?
Sure.
Awesome. So first what I'm going to do is make sure that the blood pressure cuff is applied properly and to bare skin. So I want the artery arrow on Kate's brachial artery. I'm now going to place my stethoscope on the brachial pulse and ask Kate to relax her arm while I inflate the cuff until I can no longer hear a radial pulse. Could you please hold that for me?
Sure.
Thank you. Right. So now I'm inflating the cuff. Right, I'm now going to slowly release the pressure. When I hear the pulse, it is systolic, and then when the pulse disappears, that is my diastolic. My measurements were 110/70, which is within the normal range of an average adult, which is 120/80. So the last assessment I'm going to do is a respiratory assessment. First, I'm going to measure Kate's respiratory rate by looking at her breaths per minute. So I'm going to watch her chest rise for 10 seconds, and then I'm going to multiply the value by 6. Sometimes you can ask the patient to put their hand on the chest so you can see the rise easier if you cannot find it by looking normally. So Kate, would you mind if I take your rest break?
Sure.
Would you mind just popping your hand on your chest for me so I can see the rise? Awesome, so here we go. Great, so in 10 seconds, Kate had 3 breaths per minute, therefore her respiratory rate is 18 breaths per minute. That is in the range, in adults' normal range of 12 to 20 breaths per minute. So, lastly, I'm just going to have a little bit of a listen, if you don't mind, to your chest.
Sure.
So what we're going to do is we're going to place a stethoscope on the base and apex of each lung, both anteriorly and posteriorly. So when doing this, I'm going to ask Kate to take a breath for me. While doing this, I'm just watching and listening to any wheezing, wet sounds, stridor or absence of sound. Awesome. Well, Kate sounds completely normal, which indicates that it's unlikely she has any respiratory problems. So today I'm going to be applying a collar. So the indications for a cervical collar use is followed by the nexus, the rule which is the National Emergency X-ray Utilisation Study. So indications to put a collar on is that the patient has a posterior midline cervical spine tenderness. We have to have no evidence of intoxication, a neurological defect, no painful distracting injuries, and an alert mental state. Verbal GCS of 5 out of 5 is good. Before applying the collar, I'm going to explain to the patient what I am going to do, which is the procedure, and how to I have to gain their consent. So Steve, I'm just going to put the collar on. You might have a spinal injury. Is that alright with you? To apply the collar, Kate here is going to stabilise the patient for me. I'm going to adjust the collar from the clavicle to the base of the chin. So how I do that on the collar here is just slide it up and down. Then I'm going to lock it into place, briefly bend it, then pop it on the patient like so, ensuring that it is nice and tight so it can mobilise him. So we're just looking at the oxygen tank. So what I'm going to do is I'm going to check my Botox seal. That's all good. So it's just on the inside of the regulator. Then we're going to pop the regulator onto the oxygen tank. Tighten that there. So we check the oxygen pressure in this gauge here. We're just going to check that there's oxygen in the tank. Yep, you choose your pressure here. That's all good. So what we're going to do is we're going to attach the bag mask to the patient and flow oxygen through it. So for a bag valve mask you want about 10 to 15, and we're going to keep the oxygen tank lying down so there's no chance of it falling off the stretcher. Cool, so I'm going to turn this on, pop it round to 15, we can hear it coming through the mask here. Next to fill the bag. There we go, filling the bag with a reservoir. Chest rise, then what we can do, when we've oxygenated the patient, we need to turn off the cylinder, pop it back round to 0. turn it off. But we just want to ensure that all oxygen is bled out of the regulator. When dealing with hemorrhage control in patients, the first thing to do is make sure I'm wearing my PPE, my glasses and my gloves. For catastrophic hemorrhage, I'm going to apply a tourniquet to the bone, the proximal bone of the wounded arm. So, I'm going to apply the tourniquet above the wound so I can cut off the blood supply. First, I have to expose the wound, the limb, and then I slip on a tourniquet, and I have to tighten using the windlass until the bleeding stops or the distal pulse disappears. If one tourniquet does not stop the bleeding, I can apply a second one. Lastly, I have to document the time that I apply the tourniquet. So, for example here, I've applied it at 11:20 hours. So, for a non-catastrophic hemorrhage control, first I want to check again I'm wearing my protective gear, gloves and safety glasses, and I want to expose the wound and clean it with a saline solution if needed. This will remove any dirt, reduce the risk of infection and clean the wound. If it's not necessary, I can just use the dressings to pack the wound. Otherwise, I'm going to have to cover the wound with the smallest dressing possible. So, when bandaging over the dressing, I am going to twist and tighten the bandage to stop bleeding. This also puts extra pressure on. So the bandage needs to be tight to stop the bleeding and put pressure on. After the bandaging is done, if the blood continues to seep through, I can also add a second bandage over the top. I can also ask the patient once I'm finished to elevate their arm and apply a bandage here under the armpit, which reduces the circulation of the blood and will hopefully control the bleeding. So today I'm going to splint Michael's leg, who I believe has a suspected fractured patella. But first I have to explain the procedure to the patient and gain some consent. I'm going to expose both legs and compare the injured to the non-injured leg. I also am going to use the Plucidix acronym and to carry out an assessment. So first, after I've compared the legs, I need to assess his loss of function. Can you move your toes for me? Have you tried to bear weight? I've also noted that the leg doesn't have any unusual movement. Bone through the skin irregulations, shortening or swelling, rotation, no crepitus. To assess the cardiovascular integrity of the injury of the limb, I'm going to compare the distal pulses, which are even. The colour of the skin is pink in both feet, and the temperature is warm in both of them. The capillary refill is 2 seconds in both. And to assess neurological integrity, I'm looking for pain, feeling, movement of the injured leg. So I'm going to rub the bottom of each foot. Can you feel this, Michael? Michael, can you give me a pain scale of 1 to 10, please? Okay, Michael, I also just need to let you know that there's some possible side effects to Methanox, so that's drowsiness, lightheadedness and nausea. But these are all very rare. So, you can obey commands, Michael, that's great. So as an adult, I am going to administer 2 doses of 3 milliliter ampule liquid through the plastic inhaler and double check that I have the right patient, the right drug, the right dose, the right route of administering the drug and the right time. Alright. What's your pain now, Michael? Okay, I'm going to use the cardboard splint to stabilise your knee and I'll explain to you what I'm doing. Alright, Michael, so how's your pain? Alright, awesome. So I think the pain relief is effective. So what I'm going to do now is I'm just going to splint your knee. So I'm going to put the cardboard underneath your leg. I'm also going to use a towel for extra comfort. Please let me know if your pain gets worse and we can do something about that. So what I need to do now is I'm just going to tie a bandage, one above your knee and one underneath your knee, and that will hold the splint in place. Right, I'm just putting it around twice just for extra stability. Now I've just got to do the one below your knee. Alright, now that we've got that leg stable, I'm just going to assess your neurological and cardiovascular function and integrity again. So, can you wiggle your toes for me? Can you feel me touching your foot? Alright, awesome. So Michael also has equal distal pulses on both legs. Both feet are pink and warm, and the capillary refill is still 2 seconds in both feet. So this indicates that the splint isn't cutting off his neurological or circulatory pathways. So what we're going to do is we're going to turn the defib on. The test load, which I've already previously put on, is located in the back of the defib. And what we're going to do, we're going to put it into manual mode, and we're going to put the joules down to 50, and we're going to click the middle button here. What we're going to do is we're going to do a test charge. So charge is charging to 50 joules. And what we're going to do is we're going to shock. Shock has now been delivered. Now what we're going to do is we're going to charge. However, this time we're going to disarm the shock. So in order to do that, we press the knob. So therefore, no shock has been given. What we do need to run is a user define. So what we're going to do is we're going to go to options, and then we're going to put the user test here. What we're going to do is we have to check these sensors. So on the right hand side, and we're going to attach this here, and it's going to analyze. And it's searching for my pulse currently. Now the user test is in progress. Now after that's analysed, we can see here that it has been passed. So what we do is we now rip. We look for the user test passed, so we know it's in working form. In case that we need to change the paper for here, it is located in the back once again. We would open it up and we will push it in and change it via here. So what we're going to do here is we're just going to change from AED mode to manual here. So I've clicked the advisory, enter manual mode, no. Click it again, enter manual mode, turning the knob here, and enter manual mode, yes. So previously I have attached the ECG leads to myself, left leg, left arm, right arm. On a patient it would usually go on their chest, however I'm not going to take off my shirt today. So as you can see on the live stream here, we are analysing my heart rate and using the ECG leads. In order to change the leads, we press the lead button. Using the knob here to rotate, we can choose which one we like. If in the event, for example, the lead comes off your patient's arm, a dash line will show up. And it will also tell you, for example, LA lead is off. So what we can do is just pop it back on. After that, in order to change the size, so it goes anywhere between 0.25 to 4, we can choose whichever one we like, so size, and then change it with the knob and press the middle button to pick your size. Now, in order to change the sound, we press the home button here. We use the knob to turn until we get to the heart rate, how it's highlighted. Press that one, knob again, QRS volume, turning it right up, as you can hear. Now we'll turn it back down. QRS volume again. Now we press the home button. I don't have a patient today, but when I would, we would measure the SpO2 volume from here. What we do, place it on the index finger, nail just up to the top, and it will analyse. Has to be a bare finger as well, even if there's nail polish, generally won't work. Here's the rotator cuff to measure blood pressure. What we do, wrap it around the patient on their arm, BP, and it will show up in the box here. Lastly, for CPR, if needing to do it, all the defib stuff is located here, so we've got some defib pads in this pocket here. We've placed them on the patient. We've got our load and everything like that, so we can charge when needed to. Yeah, so this side is where all CPR stuff is kept. Here's ECG leads, SpO2 and blood pressure cuff. What we're going to do is we're going to turn the machine off and we're going to pop everything back. So we're approaching the patient, we've got a call out. I'm just checking for dangers as we walk in. So I've checked for dangers, right. I'm just going to check for response. Hello, can you hear me? Alright, no response. So airway checking, tilting the head back, checking for obstruction. Doesn't appear to be one, I'm just going to look for breathing. No sign of breathing, I'm just going to listen for 10 seconds. Check for response, no response. So what I'm going to do is I'm just going to call for backup. AT1 control. Yeah, look, R49 requesting an R50 backup, please. Can you please start CPR for me? I'm just going to set up the defibrillator. So CPR is given at 100 beats a minute. Right, stand away, clear the patient, please.
Analyzing heart rhythm.
Go clear.
Do not touch the patient.
Clear.
Shock advised.
Clear the
Charging.
patient, shocking, charging.
Stay clear of patient.
Clear.
Deliver shock
Right,
now.
I'm delivering
Press the
shock.
orange button now. Shock delivered.
Right, let's see if we start CPR again. Right, so I'm just going to insert an OPA, tilting the head back, and rotating there. So, I'm just going to pop some oxygen in, so just hold off on compressions, please. Alright, watch your chest rise. Hold. So also I'm going to deliver some oxygen through the tank, 15. Right, so one thing to watch with the oxygen is just that the mask is sealed properly.
28, 29, 30.
Awesome, thank you. Cool, and we also need to make sure, there might be an obese patient, just looking at that. So the age of the patient also, whether they have teeth or not, the neck mobilisation, stiffs and snores.
27, 28, 29, 30.
Chest rise, chest rise. So compressions here about 1/3 in depth.
27, 28, 29, 30.
Chest rise, chest rise. While this is happening, I can be obtaining some patient history. So asking family or friends, asking anyone around the scene how this occurred. More information is best. Any, medications, relevant information.
28, 29, 30. 27, 28, 29, 30.
Chest rise, chest rise. Clear the
Stop
patient,
CPR.
please.
Close swap.
Analyzing
Yes.
heart rhythm.
So after the analyzing,
Stay
swap.
clear of patient.